नमस्कार, वेलकम टू आरसीआई नवशिखर चैनल। आप सभी का आरसीआई के नवशिखर चैनल में स्वागत है। आज का हमारा टॉपिक ऑफ डिस्कशन है आइडेंटिफिकेशन, असेसमेंट एंड मैनेजमेंट ऑफ चिल्ड्रन विद मेंटल रिटार्डेशन एंड विद मल्टीपल डिसेबिलिटी। और इस डिस्कशन के लिए हमारे साथ एक्सपर्ट हैं। टू माई एक्सट्रीम लेफ्ट इज मिस हेमा गौरी। शी इज अ फ्रीलांसर इन द फील्ड ऑफ स्पेशल एजुकेशन, and with her another expert is Dr. Shanti Mathur. She is also in the field of special education. ये दोनों एक्सपर्ट हमें आज के बारे में इंफॉर्मेशन देंगे। मैं अपने व्यूअर्स को बोलना चाहूंगी इस रिगार्ड में उनकी जो भी क्वेरीज हैं, अपने व्यूज शेयर करना चाहते हैं तो हमारे टोल फ्री नंबर पे कॉल कर सकते हैं। हमारा टोल फ्री नंबर है 1800111208, 265111613। हमारा फैक्स नंबर है 265111609। तो आइए हम अपने एक्सपर्ट के साथ हमारी आज की डिस्कशन स्टार्ट करते हैं। वेलकम मैम। वेलकम मैम। जैसे कि आज का हमारा टॉपिक ऑफ डिस्कशन है, इट्स रिगार्डिंग द स्टडिंग द ड्यूअल कंडीशन मेंटल रिटार्डेशन विद मल्टीपल डिसेबिलिटी। और इसके बारे में आप हमें बताएंगे कि हम कैसे असेस कर सकते हैं और उसका कैसे हम मैनेजमेंट प्लान कैरी आउट कर सकते हैं इन बच्चों के लिए। मैम, जैसे कि हमारे व्यूअर्स जानते हैं कि मेंटल रिटार्डेशन क्या कंडीशन होती है, और अगर मल्टीपल डिसेबिलिटी भी है उस बच्चे को साथ में, तो उसके बारे में आप बताएंगे कि किस तरीके से हम उनको स्क्रीनिंग कर सकते हैं, उनका असेसमेंट कर सकते हैं, और डिपेंडिंग ऑन दैट असेसमेंट हम उनका कैसे मैनेजमेंट प्लान कैरी आउट कर सकते हैं। तो इसके बारे में आपके क्या व्यूज हैं?
ओके मैम, एक्चुअली नॉर्मली मेंटल रिटार्डेशन का क्लियर मीनिंग है देयर विल बी 3 फैक्टर्स वी हैव टू चेक वेदर IQ 70 के नीचे जाएगा, इट्स बिलो देन 70, देन देयर विल बी अडैप्टिव बिहेवियर प्रॉब्लम दैट कम्स इन द 3 एरिया, conceptual level, practical and social level. Apart from it, age should be 18, up to 18. Okay, this is the main, but our topic is MR with associated condition could be multiple disability. Normally multiple disability refers to more than one disability. It could be a child with visual impairment, maybe along with MR, then ma'am, actually when we call it as a multiple disability, first is the primary condition regarding our topic, it is mental retardation. Okay, the second factor, secondary disability could be visual impairment, hearing impairment, orthopedic, seizure, ASD, autistic spectrum disorder. Again, it could be any other things like microcephaly, macrocephaly, hydro. It will any kind. Now, the main thing is how to identify.
जी,
Okay, because identification is the main problem, because MR again covers mild, moderate, severe, and profound. If the child is at the mild level, say for IQ is 69, along with the impairment, say for example it is a mildly hearing impairment, say for around 25 decibel, 28. Mild hearing impairment is not that way identifiable. When normally a child with mental retardation, when we label multiple disability, in case the multiple disabilities factor, physical features, if it is very clear, like visual impairment, it's very clear. If it is cerebral palsy, there is no need to go for any clear identification, direct assessment. Actually, I will convey what are the steps, what is meant by identification, difference between assessment. First, let us clarify, when a child is identified with MR with other disability means, again it depends upon what factor it is. If it is with, say for example, autism spectrum disorder, again normally parents feel the child is having autism. First they won't focus on mental retardation, because the development with all the milestones will be normal, there won't be a delay, then automatically there is a suspicion regarding autism, then automatically they will think it is a child with autism, take the autism that assessment, and again in the course whether it comes severe or mild, moderate, accordingly they label. So in the identification process, let us first go what are the steps in that, ma'am. Let us move to the slide. Screening and identification. Screening is a procedure that identifies a person who needs further assessment for diagnosis of a disability. Screening helps in suspecting disability in a person. A screening procedure does not confirm disability but helps in shortlisting for detailed assessment. Identification. Identification is finding out children's special needs. It is an outcome of screening. It is a process by which children with disabilities are identified for further assessment. Actually, screening procedure helps a lot. Screening in the sense whether, okay, say for example there is a developmental delay in the child.
जी.
Okay, because our topic is not just MR. Then other associated condition, if it is visible, there won't be any delay in go for assessment or checking whatever issue. If it is, again it is dyslexia, say for example it is go unnoticed, the child development, okay, normally all parents will tell, no ma'am, in our family even my husband is delayed development, is late, speech also delayed normally. Because comparing in the disability group, mental retardation means it's in the intellectual area, it takes time parents to agree it, so automatically the diagnosis takes time. But in the screening process, in the sense any developmental things, if it delays, okay, then they can go for the testing of the child, what the problem. Again let us move to the screen, I will show the steps. Stages in screening and identification. Screening, then moves to identification, moves to referral for assessment, it moves to diagnosis, again it is confirmed MR with associated condition. Actually, screening conveys the child may have, it is a suspicion, it's not conformity,
Confirmation.
no, the child is having disability. Again, if we talk about the screening, depending upon each disability condition, the screening scales are available. Okay, by checking, again screening we can do independently or even a group screening also possible. The questionnaire in the screening will be very limited, minimum 10 or 5 questions. We will look about the Indian versions
Some
of it.
checklist may be
The
included.
screening schedule we are having 3. We will see in the next
Okay.
slide. Okay, by checking minimum 10 questions. Say for in India, okay, let us view the screening schedules in India. I will give that example. We'll move to the slide. Screening tools in India. National Institute for Mentally Handicapped (NIMH) has developed 3 screening schedules for quick screening. They are: number 1, screening schedule 1, below 3 years; number 2, screening schedule 2, 3 to 6 years; 3, screening schedule 3, 7 years and above. Apart from this, developmental screening test DST by Bharat Raj is a widely used screening tool by professionals. Actually, screening, in case if you take about schedule 1, it covers less than age 3. Roughly there is only 13 questions. There is no need for a professional to do the screening test. Any person who is educated, trained CBR workers, anybody can, just asking the parent the questions. Developmental milestone will be there. Delayed month, how long it is delayed, both the factor will be there. Among the first schedule there will be 13 questions, in the sense first 11 question, if only one answer is coming yes, and again for the second question 1, then only 2 questions are ticked as yes, in the sense now there is a suspicion the child may have MR, then they will identify. Actually, identification means now they are identifying there is a suspicion that he may have MR, now sent for assessment. Because assessment is a diagnosis process. Assessment only confirm the child is having this. Okay, even if you take the schedule 2, screening schedule, it covers age up to 7, in the sense just only 10 questions. 10 questions, only yes or no. No, nothing else. We are doing it even in the group screening also. We are calling in the, when we are working in the CBR program, there will be a big group gathering. We will be there, take the photocopy and issue to the people in the public. Just we will announce the mic. The first question, if it comes yes, tick it. That's all.
So some educated person can do that.
Help anybody. So it is a very good thing. It helps a lot of this thing. Okay. Even screening 3, it has only 8 questions. After age 7, it covers. Okay. When we take a developmental screening test, it is contains 88 items, but maximum professionals can do it. Screening test first confirms the child may have MR. Now our topic is with associated factors 2 means. Again, visual problem parents can identify quickly.
Like जैसे physical problems होते हैं, it's
It is
easily
noticeable. It is
identifiable.
noticeable. When other suspicious factor, even if you ask me, there is one problem, developmental disorder is there. It covers the delay in development will be there. Up to age limit is 22. not 18 like mental retardation factor. So up to age 18 the developmental will be there. And one more important aspect is there is no worry about the IQs. There is a difference. Again developmental delay is there. So there are certain disorders that again have a confusion among is it MR or delayed developmental disorder. Only that one. So again the screening schedule depending upon the disability we make accordingly.
मैम जैसे आपने बताया कि स्क्रीनिंग शेड्यूल इट डिपेंड्स अकॉर्डिंग टू द डिसेबिलिटी, और जैसे आपने अभी बताया कि डिपेंड्स ऑन द एज, और उसकी चेकलिस्ट होती है जिसमें डिफरेंट क्वेश्चंस होते हैं. मैम इसके बारे में आप क्या कहना चाहेंगे, आपके क्या व्यूज हैं?
No, the screening is essential because when the child walks in, the parents don't give immediately the problem. They only say, "ये बच्चे बोलता नहीं है."
जी.
This child doesn't talk. This child doesn't walk. So you'll have to screen the child and see why the child is not walking in this proper age like his peers. So the screening test is very, very important. So we use the checklist to make it very convenient for both the professionals and the parents. So by the checklist you know where exactly the laxity, where exactly the child falls below the average level of things. So that's a very important. And as far as DST is concerned, because that's my personal experience, it's one of the best screening tests in India.
Maximum DST professionals are using.
We
Not
are
lay
using.
person,
It must
ma'am.
be
A lay
including
person
different
cannot, because it's
items
not
from-
available.
It is not available, but if you take screening schedule 1, 2, 3, any lay person can
Can
use.
also use it.
But DST only professionals.
प्रोफेशनल कैन डू.
Because
So
it's,
DST must be including items from different areas.
Areas and ages.
Yes,
Age
yes.
also for all
Yes.
wider age.
It's
It
age
covers.
wise. It's just 6 months onwards to 6 months to 15 years in various areas like communication, motor development, sensory development, and everything is covered in item wise.
तो डिफरेंट आइटम्स होते हैं और उस चेकलिस्ट में डिफरेंट एज ग्रुप के अकॉर्डिंग असेसमेंट करते हैं.
असेसमेंट होगा. इवन उसमें ये पता लगेगा देयर आर सस्पेशन ही मे हैव, लेट अस रेफर द चाइल्ड फॉर असेसमेंट ऑन पर्टिकुलर डिसेबिलिटी.
जी.
Okay, then again we are having medical screening, ma'am. Let us move to the screen and I will explain about it. Medical screening. A, prenatal procedure. Number 1, blood test in the mother. 2, ultrasonography. Number 3, amniocentesis. Number 4, photosynthesis. Number 5, chorionic villus sampling. B, neonatal and postnatal procedure. Number 1, ABGASCO. Number 2, urine screening for metabolic errors. Number 3, blood biochemistry tests for cretinism, jaundice, etc. Number 4, chromosomal analysis. Number 5, electroencephalogram for seizure disorders. Number 6, visual screening, that is visual acuity retinoscopy. Number 7, auditory screening, BERA, tympanogram. Number 8, ultrasonogram. 9, CT scan. 10, magnetic resonance imaging, MRI for intracranial pathology and structural anomalies. Ma'am, actually screening in the sense, the first prevention is the prenatal screening. In case there is a suspicion in the family, if one of the sibling or somebody is having, naturally if we go for this is screening of tests, blood tests, certain time RH incompatibility may be a factor for this one. Or again, if you take in the prenatal this thing, amniocentesis, normally they start around the second trimester, around 16th to 18th week is the time they can do it. 20 ml amniotic fluid they will take, but it helps a lot to understand. Normally we call amniocentesis even in case they identify the child may have MR with other associated, definitely translation of the pregnancy is cut off, they are doing medically. Again, if you take in the prenatal stage the CVS, chorionic villus sampling, it is very crucial testing, only efficient professional can do, but definitely within 24 hours we get the result. When we are doing amniocentesis test, definitely it takes time around 3 to 4 weeks to get the result. Okay, again it is in the second trimesters. Because one of the example I can give, one of the mother in our center, she is the first child is with microcephaly with vision problem. Again mental retardation. Okay. Normally when microcephaly comes, mental retardation casually occurs. Okay, certain times microcephaly with autism features also comes. Then for the second issue, we request that the mother, you better ask the doctor, is there any testers available, then try for the second child.
मैम जैसे आपने बताया कि माइक्रोसेफेली कंडीशंस भी हो सकती हैं, और अभी हम बात कर रहे हैं स्क्रीनिंग के बारे में, प्रीनेटल जैसे स्क्रीनिंग हो गई, तो उसमें क्या हम आइडेंटिफाई नहीं कर पाए कि माइक्रोसेफेलिक हो सकता है?
होगा, वही बोल रहे ना, इफ यू आर टेकिंग द अल्ट्रासोनोग्राफी, it everything comes, but in the second trimester, not in the first one. So again, see ma'am, normally who will go for screening test? Normally any pregnant woman, they won't go for any screening specifically. In case they are having certain children or in the relatives, I am telling, when we are doing the training procedure, we will write the pedigree chart. In case there is a third generation jumping of disability in the group, we normally convey to the parents, when we are giving guidance to the parents, please ask your relatives, go for the screening test before the pregnancy time. But normally they will avoid.
Like you have said कि फर्स्ट ट्राइमेस्टर में इतना स्क्रीनिंग का नहीं
CVS
होता
का
है,
है, CVS क्रॉनिक
पर मैम जैसे अगर हम कुछ रूल्स की बात करें कि अब आजकल जो होता है कि अगर हम कहें कि अबॉर्शन के बारे में अगर हम बात करते हैं, बट वी कैन गो इन द सेकेंड ट्राइमेस्टर.
No, when we are doing amniocentesis, medically agreed transfer of mother's pregnancy is agreeable. The child with mental retardation and any cerebral fissure, whatever it is there, depending upon the severity of the condition. I can convey one of the child, he is having corpus callosum problem, all the cleft palate, heart hole, everything, but they identified only at the month of 8th. Before that, nobody go for specifically for a CT scan. This who will go for 3rd month and all. Even if you take CVS blood sampling test, it exactly in the 9th to 11th week, before 3 months. But normally, who will go for such a test? Because the parent, normally when a child with disability comes, then there is a problem whom to contact, where and all. So normally in the prenatal screening, the input depending upon their own thinking, okay, in my family my sister is having, say for example, then let me go for pre-screening, prenatal test, that is agreeable. Otherwise, even if you take postnatal screening, if you take APGAR score, it is literally helps a lot, because APGAR score, just as the child takes birth, within 5 minutes we will notice the scoring has to come up to 10. If it is less than 7, in the sense, definitely there may be a problem. So during the birth time itself, the hospital doctors will give the APGAR score. It is
like we are talking about the APGAR score. तो बेसिकली ये जो APGAR स्कोर है, ये किस चीज के बारे में बताता है?
APGAR score, it will tell the child will face problem if the APGAR score goes less than 7, definitely.
नहीं, स्कोर हो गया, but what are the details?
At times it is not identifiable. The child will be normal. Other problem will be there. It takes time, because when the child is coming to the special school, checking the medical history, during the assessment process, the medical history will come.
जी.
Okay, birth time the APGAR score is there. Doctors will write and give. That's all. Okay, but as the child developmental delay comes, they again, maximum if you take identification, it is in the hand of doctors, pediatrician, as the child takes birth. If there is any featural difference, facial difference like Down syndrome, automatically parents will agree it. Even it's a painful
Because it's visible to them.
It is visible. Even MR with any multiple disability, whatever it is visible, it is easy for to notice.
Like in some cases we can see के visible problem होती है, like जैसे CTV की problem होती है, तो parents easily identify कर सकते हैं कि पैर के मतलब कुछ anatomy और physiology में कुछ problem है, तो वो easily trust कर सकते हैं कि yes there is a problem with the child. But if the problem is not visible, then
that's what I am telling. If it is a two intellectual disability coincidence, say for example, if it is a child MR with autism spectrum disorder, again it is the biggest question mark to identify. There won't be any facial difference at all. The child looks charm, all the milestone, gross motor milestone will be normal up to even age 2 or 1.5. It get delayed. So automatically it delays. Even when autism spectrum disorder comes, okay, nowadays because of the orientation in the public, it is little bit coming, but even dyslexia, automatically it delays more, because the child gets more time. As this child enters the school, parents think, okay, he is not reading very well, let us change the school or change the teacher who is taking, or it will take time, he will change. Up to even age 7 and 8, it get delayed. Okay, even if you take in the rural area, the universalization of primary education helps us up to 8th standard the child will pass in the school. Then automatically parents, ma'am, if you take in the any rural area, remote rural area, any child with mild MR with dyslexia or autism, whatever it is, it goes unnoticed because parents will feel even if it is a mildly hearing impairment, automatically they will have a knowledge when you are talking to the child, raise your voice. That's all. They won't go for hearing test because mild hearing impairment is even moderate impairment also. Certain parents still are not agreeing to put the hearing impairment. The child is having MR with autism spectrum also.
If we see to the environment, like we are talking about the rural and urban, ये भी एक फैक्टर है कि लोगों में अवेयरनेस नहीं है इस चीज की. They are not aware कि there can be anything like that in the society.
इसमें नहीं, in our India there is a good scheme like in the IED, Integrated Education Program and Service Shiksha Abhiyan, there is a nice questionnaires. Just a question mark whenever any child joins in the first standard. There will be just a questionnaire, all the visual testing, hearing, apart from it medical reports, plus whether the child attended any other kindergarten school wherever it is.
So
What
is
is the
it
academic academic feedback they are writing it. There itself they will trace. There may be a suspicion, let us send for assessment procedure. They can't identify particular disability correctly, but there is a suspicion, let us send the child for assessment department. They will refer.
Is it a part of their academics?
Yes. No, it's not. It is the entry.
Like जैसे
admission.
आपने कहा कि स्कूल में एडमिशन लिया बच्चे ने, तो उसका एक जो आपने टेस्ट बताया IED,
Integrated education system. Ma'am, I am telling we are having GLAD, grade level assessment device.
Ji.
Okay, NMH has launched it already. It is up to 4th standard. Who are all the children failing, getting low marks? Okay, that helps. Just a small question, every keyword is that they have to do the assessment. That conveys there is a doubt, better send the child for assessment. We are having it again in case it is in the school center they are not aware of it, means the awareness we are increasing day by day, but there is a educational assessment. GLAD is very useful, that helps a lot to identify what is the problem.
So जैसे आपने बताया कि स्क्रीनिंग करते हैं, मतलब सस्पेक्शन हो गया उसमें, तो वही हमारा स्टेप हो गया कि जैसे आपने बताया ग्लैड का, तो उसमें हमने देखा कि यस बच्चे में कुछ
In the GLAD only it starts when the child enters to first standard.
फर्स्ट स्टैंडर्ड.
So screening starts even exactly by birth of the child, depending upon the child's developmental milestone. In case the parents have any doubt, even up to age 3 the screening schedule first comes. Okay, any developmental delay along with invisible factor means that nobody will go. That is our problem. Actually in India again we are launching program to the doctors and conveying regarding the screening schedules the pediatrics can use in future, because our motto prevention in the first stage. Because as age increases definitely program screening everything is available. As it get delayed, because when the child is having locomotor problem, normally parents won't go and check for the IQs. Already one disability is labeled, it is visible, and again it takes time. They will tell because my child is not moving this, that and all, it takes time, he will learn. Automatically after age 9 or 10 or 11 they are launching to special schools. They are telling again to already one labeling is there, to add one more MR, till there is a mistake. These people in the normally they label mental retardation means pagal hai, till it is there. Even the terminology mental retardation is already taken from 2002 new definition. It is intellectually developmental disorder, IDD. It is not labeled as MR. American Association of Mental Retardation itself changed its name as AAIDD, American Association of Intellectual and Developmental Disorder. So it has been changed. The terminology mental retardation has already changed. The usage again it takes time for us, because even all of a sudden, even now if I use intellectual developmental disorder, they may think it's a new, it's not mental retardation.
terminology.
So it takes time, but screening always has a benefit. Available things we are having in our country also, because standardized screening schedules foreign also they are having. India also already it's moving across screening awareness, because only doubtful characteristic is mental retardation with other unnoticeable disorder in the sense. It takes time.
But luckily we
आप
have
क्या
school
कहना
health
चाहेंगे?
services, which every child in the school primary level is subjected to medical examination by the school health services.
जी.
There itself you can identify the hidden disorder of the child over the leaf of MR.
Any kind of
Any
problem.
kind of hidden, because many reference we get from the school health services, this child doesn't hear probably, so please examine and say. So then you send it to ENT, you send it to an audiologist, you send it to any specialist for that matter, to identify the hidden disorder of the child. So now the school health services have been very alert on this score, and they test all the children who enter into the school, and then send them to various referral agencies.
तो इट्स वेरी मच गुड बिगनिंग कि
Yeah.
अगर पेरेंट्स इग्नोर कर जाते हैं या वो ध्यान में नहीं आ पाता है उनके
तो they
बच्चे
catch
की,
them.
तो उस तरीके से हेल्थ सर्विसेज के तरीके उससे हम कैच कर सकते हैं उस
No,
problem
because
को.
mental retardation जैसा डेवलपमेंटल डिसऑर्डर भी है, उसमें डिले इन डेवलपमेंट होगा, उसमें IQ नहीं आएगा. मैक्सिमम दे विल
IQ is not the
फोकस, इट मे बी
criteria there. The teachers only say this child doesn't perform well. So that's the suspicion we have. The
And that
child
is-
doesn't.
yeah.
Then they say, send to us. For please.
कि what are the reasons that the child is not performing.
That is the way they identify the things.
मैम जैसे हम मेडिकल स्क्रीनिंग की बात कर रहे हैं, इसमें आपने बताया प्री नेटल में ब्लड टेस्ट ऑफ द मदर, तो हाउ इट कैन बी द रीजन फॉर द.
Ma'am, because when you take the causes of mental retardation, again, even RH incompatible also one of the factor.
One of the factor.
Other blood group like jaundice or metabolic factor, even diabetes, there are so many causes that will hinder the development of the child. So that testers will help for the other sonography testers and all. They will understand the CVS test, then they will refer, let us do this. In case there is any difference in this one, they will identify. Otherwise, they are doing the second trimester starting in the 16th to 18th weeks. Definitely amino sentences, normally just 10 to 20 ml only they will take the amino sentences. They will clarify not only mental retardation, that intellectual decision, other any physical feature difference also, it will be traced.
तो लाइक डिफरेंट फैक्टर्स आर देयर.
But again, everything is good. Prevental screening issue is there. But again, who will go for that test? Normally, who are pregnant lady, it's not possible to every screening test will go for chromosomal checking, this, that, and all. Only the thing, in case there is a child in that family, we can refer. Otherwise, it's a complicated question. They refuse. Pregnant woman, normally they will go and check. It's not nice to say it's male or female child. Sorry. There it ends up. Otherwise, scanning anything, nothing is possible. Only in the 9th month, the head of the child is whether this position, whether cesarean or normal delivery. That time they are doing. So screening tests are available. But the knowledge of, in case there is a suspicious case in the family, it is better to go for the prenatal medical checking. That is our information to the public, because all prenatal and natal blood checking, everything is available.
तो मैम जैसे आपने बताया कि मेडिकल स्क्रीनिंग के जरिए हम पता लगा सकते हैं अर्ली एज में भी ड्यूरिंग प्रेगनेंसी के कुछ प्रॉब्लम है या नहीं, और इसके लिए हमारे डिफरेंट स्क्रीनिंग टेस्ट अवेलेबल हैं जैसे कि हमारे एक्सपर्ट ने बताया. इसकी बाकी की डिस्कशन हम एक छोटे से ब्रेक के बाद कंटिन्यू करेंगे. दिस इज टाइम फॉर अ शॉर्ट ब्रेक.
हम होंगे कामयाब, हम होंगे कामयाब, हम होंगे कामयाब एक दिन. हो मन में है विश्वास, पूरा है विश्वास, हम होंगे कामयाब एक दिन. We shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe that we shall overcome someday. We shall overcome someday. we shall overcome someday.
The state of knowledge exists. The will, the capacity, and method are usually the problem. मानसिक मंदता एक ऐसी विकलांगता है जो 18 वर्ष की आयु से पूर्व कभी भी हो सकती है, जिसमें व्यवहार अनुकूलता में कमी एवं बुद्धि क्षमता 70% से कम होती है। Alone we can do so little. Together we can do so much. भारतीय पुनर्वास परिषद द्वारा देश भर में पंजीकृत केंद्र इस बात को प्रमाणित करते हैं। NIMH प्रादेशिक केंद्र नई दिल्ली एक ऐसा ही केंद्र है जहां छात्रों को प्रशिक्षण दिया जाता है। जिसके उपरांत वे मंद बुद्धि बच्चों की सेवा में नियुक्त होते हैं। क्लासरूम टीचिंग, ग्रुप टीचिंग एवं भारतीय पुनर्वास परिषद के नव शिखर चैनल पर प्रसारित टेलीकॉन्फ्रेंसेस द्वारा संबंधित विषयों पर विस्तार पूर्वक ज्ञान दिया जाता है। मेडिकल, ऑक्यूपेशनल थेरेपी, फिजियोथेरेपी, स्पीच थेरेपी, साइकोलॉजी और स्पेशल एजुकेशन जैसे क्षेत्रों में छात्रों को प्रशिक्षित किया जाता है। प्रयोगात्मक अनुभव एवं अभ्यास के लिए टीचर ट्रेनिंग प्रोग्राम के उपरांत छात्रों को मंद बुद्धि बच्चों के साथ कक्षाओं में नियुक्त किया जाता है और इंडिविजुअलाइज्ड एजुकेशन प्लान का भी आधार बनाया जाता है, जिससे वे संपूर्ण शिक्षा एवं चिकित्सा शैली को समझ सकें। इस पूरे प्रशिक्षण कार्यक्रम के दौरान विद्यार्थी जर्नल्स, न्यूज़लेटर्स, पेरियोडिकल्स, चार्ट्स, मॉडल्स, कंप्यूटर ट्रेनिंग एवं टेक्स्ट बुक्स का उपयोग कर सकते हैं। कहते हैं, कीप योर फेस टू द सनशाइन एंड यू कैन नॉट सी द शैडो। इसी बात को ध्यान में रखते हुए विद्यार्थियों को सरकारी एवं गैर सरकारी संस्थाओं में नियुक्त किया जाता है, जहां वे मंद बुद्धि बच्चों के लिए निरीक्षण, प्रशिक्षण एवं अनुसंधान का दायित्व संभालते हैं और इसके पश्चात ये विद्यार्थी इस प्रशिक्षण का उपयोग मंद बुद्धि बच्चों के सामाजिक एवं शैक्षणिक उत्थान एवं विकास में करते हैं और एक लक्ष्य की ओर आगे बढ़ते हैं। और फिर लक्ष्य कितना ही दूर हो, फासला नजरों का धोखा भी तो हो सकता है। वो मिले या ना मिले, हाथ बढ़ाकर देखो।
वेलकम बैक टू आवर डिस्कशन। हम ब्रेक में जाने से पहले हमने डिस्कस किया था कि हम मेडिकल स्क्रीनिंग किस तरीके से कर सकते हैं और इसको हमने देखा था प्रीनेटल, पोस्टनेटल और डिफरेंट एस्पेक्ट्स जो इसमें हम कंसीडर करते हैं, ये हमने अपने एक्सपर्ट्स के साथ डिस्कस किया था। इस डिस्कशन के लिए हमारे साथ जो एक्सपर्ट है मिस हेमा गौरी, शी इज अ फ्रीलांसर इन स्पेशल एजुकेशन, और डॉक्टर शांति माथुर, शी इज क्लिनिकल साइकोलॉजिस्ट। हमने अभी तक देखा कि किस तरीके से हम स्क्रीनिंग कर सकते हैं, विच इज द फर्स्ट स्टेप फॉर द सस्पेक्शन, इट इज नॉट द कंफर्मेशन स्टेज। आइए हम अपने डिस्कशन को आगे बढ़ाते हैं और इस पार्ट में देखते हैं कि किस तरीके से हम बच्चों का असेसमेंट कर सकते हैं। और हम डुअल कंडीशंस के बारे में पढ़ रहे हैं, मेंटल रिटार्डेशन जिसको हम अब आईडीडी के नाम से कहते हैं, जैसे कि हमारे एक्सपर्ट ने बताया, इंटेलेक्चुअल डेवलपमेंटल डिसऑर्डर विद मल्टीपल डिसेबिलिटी। तो आइए हम अपनी डिस्कशन कंटिन्यू करते हैं। मैम, जैसे कि ब्रेक में जाने से पहले हमने स्क्रीनिंग के बारे में देखा और ये देखा कि मेन जो टैगलाइन हम इसमें देख सकते हैं कि स्क्रीनिंग इज द फर्स्ट स्टेप फॉर द सस्पेक्शन, इट्स नॉट द कंफर्मेशन। तो नाउ वी आर कमिंग टू द पार्ट ऑफ द असेसमेंट। तो हाउ वी कैन असेस द चिल्ड्रन विद आईडीडी एंड मल्टीपल डिसेबिलिटी?
First of all, I would refer to the screen and see what is assessment. What do you mean by assessment? After screening a child, we want to have an assessment done to confirm the suspicion. So for that, we'll have to gather a lot of information. In technical word, we call it as a case history method. You see, every child walks in, then we have the information gathered by the parents, neighbors or school teachers, whoever is available as far as the problem of the child is concerned. We gather all this information to have a proper guidance given to the child, a proper decision to be taken to the child, and how we can use this information for the administrative purposes of that individual. That is the meaning of assessment. So assessment cannot be done by a single person for that matter, because there are various areas involved with that particular individual. So we have team of experts who confirm the diagnosis. So the first and foremost, we subject the child to the medical examination, and the medical person examines the physical health of the child and all the organs like visual, hearing, tactile, everything is okay with the child, or is there any deficiency in that particular child. So that medical history is physical examination and medical history is very important for us to know which could be a cause of retardation sometimes. For example, if the child has hypothyroidism, that causes mild mental retardation. But unless and until that hypothyroidism is found out, detected, the child will be just named only NMR with no corrective measures taken. So if we subject the child to the medical examination, the doctor says, no, this is hypothyroidism, put the child on thyroxine. After certain times, we watch the child's behavior. So maybe 6 months, 1 year, the child may pick up and come to a near normal stage. So if undetected, the child's future is bleak. So if it is found in a particular time and an earlier stage, is always much better to correct the deficiency in the child. The same way, visual. The child cannot see the board, that cannot learn. But the complaint comes from the teacher, ये कुछ लिखती नहीं है. The parents also that I don't know, she cannot write anything. Maybe something is wrong with her hands. The physical examination says there is nothing wrong with the hands. So visually the child is not able to see, or not able to write. So if the child is again sent to a specialist, eye specialist, and the correction is made, maybe she will gain confidence and do the things in a normal way. The same goes with the hearing impaired child. The child cannot hear, the child cannot speak, or the child cannot understand what you are saying. So that is a multiple handicap, but how it hides the diagnosis, you see, that is the problem. So you have to subject each and every child for a medical examination to be on a firm ground to say this child has only MR, no other associated problems, or even for that matter autism. It's always mistaken for an MR. Autism spectrum disorders is always mistaken for an MR in diagnosis. So you have to have a differential diagnosis there. So whether MR or autism, what is the primary problem of the child? So for this we need the examination done by the medical experts to know what exactly is the cause of the even epilepsy for that matter. Recurrent attacks of convulsions do affect the child mentally, cognitively at least. It does affect the child.
हम लाइक जैसे आपने बताया कि कुछ जैसे ड्यूरिंग द बर्थ कुछ रीजंस ऐसे होते हैं जो कॉज कर सकते हैं मेंटल रिटार्डेशन, तो कुछ रीजंस होते हैं जैसे लैक ऑफ ऑक्सीजन या उसी टाइम अटैक्स पड़ते हैं, फिट्स पड़ते हैं, तो can it be the reason?
And the other conditions, malnutrition in the child. If the nutrition level of the child while going till 2 years is not sufficient, the child may show pseudo retardation. And if it is corrected at that stage, malnutrition, the child may pick up slowly and come to a near normal level of functioning. So these are associated problems with the MR, which the doctors can immediately find out and give some corrective measures for that. That's why the clinical assessment is very, very essential for every child. After the clinical assessment is done, then we go to the psychological assessment to know the level of functioning of the child for two reasons. One, for the placement of the child, or for the rehabilitation, educational purposes, and rehabilitative measures can be taken according to the level of the child. For that we use very many tests in India, and all of them are Indian standardized tests. We don't anymore use the US or UK tests. All the tests have been Indianized, and the commonly used tests in India, I would say, there are two major portions of that. One is a verbal kind of a test, another is a non-verbal test. And below the level of 3 years, when the child is not able to do any constructive tests, we can assess the child by its developmental schedules. And the developmental schedules can also be used for certain even adult age people who are very hyperactive, who are not able to do anything, and who cannot perform even their self-help skills sometimes. So that level we can use these schedules also to know their actual developmental age, and then the DQ. So DQ can be used for children as well as for the difficult adults who you cannot give a intelligence test as such. And the most commonly used developmental schedules are Gesell's developmental schedule, which is very popular. And then we have schedules developed by NIMH, National Institute of Mental Handicaps, Secunderabad, has developed screening. She talked about the screening test, but is almost like a schedule. So what the child can do up to 7 years of age. So you can compare that with the particular child and know whether the child has achieved that kind of a skill or not for that particular age. So that is the meaning of developmental schedules. So we use the Gesell's schedule as well as the NIMH and Bailey's infant scale. So these are initially used when the child is less than 5 years, or 3 years to be exact, because 3 years the Binet-Simon starts its constructive tests.
So every test has its own criteria.
So we introduce the developmental schedules when the child is very small, and after that we give them some kind of a paper pencil test to make the child feel very comfortable and happy doing that, because the children are very much like to write always or paint always, do something of that sort. So these paper pen tests are Gesell's developmental drawing, which is highly correlated with the other tests, and the draw a person test. These are all Indianized again. Gesell's developmental drawing, as well as draw a person test by Dr. Patel. So long back it was. So you just playfully ask the child to draw a person. एक बना कर दिखाओ मेरे को. So then you know what kind of a mental age the child has through that paper pencil test, so that you can make the child comfortable in his own setup, so that when it comes to a clinic it is always being scared. नहीं डॉक्टर के पास जाना, इंजेक्शन लगेगा, ये करेंगे वो करेंगे, so मेरे को नहीं जाना. So that kind of a fear is always there in the child, but we always say that we don't give an injection, we will only play with you now. So to make the child comfortable. And then you can use verbal tests, and the test which is common is now Binet Simon American version, but we have now standardized that test on all languages. And here we are using the Hindi version done at University of Kurukshetra, that has from 3 years onwards to 22 years. But that has a age level scoring. Every age has 6 items, and the child has to pass those 6 items. That is the basic age of the child. And then you will see how long it goes in the next category. Like
मतलब हर एरिया क्रॉस करते कितना आगे तक पहुंचता है.
आगे तक वो पहुंच सकते हैं. If there are 2 sequential failures in any age, then you stop the test there.
Okay.
That is the end of its ability, you can see. So Binet Simon is full scale because it has verbal as well as performance interlinked with each other. So, and it's more, one criticism of it is more academic loaded. That's what one of the criticism of Binet.
मतलब इसके आइटम्स जो होते हैं ज्यादातर एकेडमिकली रिलेटेड होते हैं.
Like mathematics, additions, subtractions, and then
different calculations.
So loaded, they say. So it's not. It can be done in most of the cases, but unless and until a child is illiterate or some language barrier, so you cannot use this Binet Simon full scale.
तो मतलब ये इसके लिमिटेशंस होगी कि अगर कल्चरल डिफरेंसेस हैं तो we cannot use this.
And the other one which we use is Malin's scale for children, intelligence scale for children. Here Malin has done it on Nagpur, where he was working there as a psychologist in Nagpur child guidance clinic. That's also another popular test which we use for the children. And Wechsler's intelligence test, which is again been standardized on Indian population. That has an advantage of having separate verbal as well as performance tests. When you want to only take out the verbal, you can take out. When you want to take out only the performance, you can take out. So that is also very popular among the tests we use. And then we use like Raven's progressive matrices, which is a culture-free test. It can be given in any culture. It has no verbal loading. And we have course block design, again a culture-free test, which can be given to any adult. And Alexander's Pagelang test. These are the 3 other tests we use to arrive at a mental age of a child.
तो जैसे आपने बताया कि साइकोलॉजिकल असेसमेंट जो हम बच्चे का करते हैं उसमें डिफरेंट टेस्ट इंक्लूडेड होते हैं. जैसे कि हमारे एक्सपर्ट ने बताया कि डिफरेंट टेस्ट कौन कौन से हो सकते हैं, जैसे मेलिन्स का टेस्ट हो सकता है, रेवेंस का टेस्ट हो सकता है, और ये डिपेंड करते हैं, इसके कुछ क्राइटेरियंस होते हैं कि बच्चे की एज क्या है, उसके कल्चरल बैकग्राउंड क्या है, और डिफरेंट फैक्टर्स हम कंसीडर करते हैं देखने के लिए कि इस बच्चे के लिए हम कौन सा टेस्ट यूज कर सकते हैं असेसमेंट के लिए.
That depends upon the individual
जी.
and the tester. what kind of test I should introduce this child.
Because
You know?
different test has different criterions, so
criteria.
we will look कि child किस category में fall करता है.
Fall karta hai. And the other test which is used here is Bhattacharya's the battery. But again, this has a disadvantage because this starts only at the age of 11 years, you see. So the children who come to your clinic before the age of 11
We cannot use.
be tested Bhattacharya's
Bhattacharya
battery. That's again a performance level. So that is very less used in clinical purpose, at least. And maybe in school settings it can be used, but when we are dealing with young children, so it cannot be used. These are, and non-verbal tests, of course, Seguin Form Board is there, very popular among all the tests. And then we have this paper pencil test and other tests. This can be used to arrive at a MA for the mental age of the child. When you know once the mental age of a child, you can know the IQ of a child. There is a formula, MA by CA into 100. And when you know the IQ of a child, you can classify the child accordingly
into the category.
into the category, like whether it's a profound, severe, moderate or mild. Above that it is average intelligence, super average, and then GDS.
मैम
So
ये
that's
तो
a-
थे जैसे कि डिफरेंट टेस्ट
Test.
जिनके हम क्राइटेरियंस को देख के हम रेफर करते हैं.
Hmm.
पर अगर जैसे हम बात करें एसोसिएटेड कंडीशंस, अगर विजुअल प्रॉब्लम है या
Yeah.
हियरिंग प्रॉब्लम है तो भी उसके साथ फिर वो एडिशनल लिमिटेशंस हो गए हैं.
Limitations हो जाते हैं. Then you have to plan out your testing. For a visual handicap, you cannot give a performance test because you cannot see. So you will base your test on verbal items, so that the child can hear and give you answers. The same way, if it is hearing impaired, you will not give any visual verbal test. We will only give performance test because the child can understand your pantomime instructions and do accordingly. So that's the advantage of the non-verbal test. You can use it with all the handicapped children and the children with language difficulty or children with any other culture. Culture barrier is not there, so the child can do it. So that's the advantage of the non-verbal test which we use in India. And for multiple handicap, like a child with CP as well as cerebral palsy as well as mental retardation, you have to see whether the child is able to perform. Because of the cerebral palsy, the child's movements are restricted. So there you may have to depend completely on the DQ of the development of the child, what the child is able to do and what the child is not able to do, and things like that. So you have to plan the necessary tests which you have to give to a particular child, looking at his conditions.
Ma'am, like for example, if we say the child is having a condition of lack of concentration, inattention,
Sometimes.
and the child is not able to sit even
Yeah,
for a
for a
5
minute,
5 minutes or for a
Hyperactive
minute.
child.
तो उस केस में हम टेस्ट कैसे कंडक्ट
Yes,
करेंगे?
you cannot conduct there. You have to again depend on developmental schedules.
And we will rely on the parents for the
For his
information.
information, and you can watch the child doing certain things. You see yourself.
I'm sorry to intervene. Actually, for ADHD, we are having the diagnostics. Diagnosis questionnaire will be there, DSM-4. There, the 3 parts come: inattention, this everything. Overall, any 2 areas, 6 point, it continues up to 6 months. Then in the diagnosis, we can add ADHD.
मतलब consistency we have to follow.
Ma'am, actually, MR with the multiple normally MR with one more disability means multiple. Main
Yeah.
primary factor is MR means we
MR.
are taking IQ. Apart from it, is an interdisciplinary team's view because we are need of assessment from other faculty depending upon the problem issue conveyed by the parents. In case as you conveyed is running this whatever it is, then again we have to the psychologist again they will do the diagnosis of ADHD. There is a DSM for diagnosis assessment for all the disability together. Even whatever it is, they will diagnose and they will convey, yes, the child is, if the problem is continues up to 6 months, then label ADHD as the associated condition. Okay, then automatically, then only the child will be labeled as multiple disabled. Otherwise, because exactly the question is good, the hyperactivity simply labeled as hyperactivity. The ADHD is not labeled as one more disability. Just they will label only as child with MR. He is just hyperactive, but he is in need of medication. The diagnosis, there is a tools. It's there. The psychologist will do, because it's a whole team approach. Let me just have a glance in the slide. The types of assessment: A, clinical assessment, medical history, physical examination, necessary laboratory tests, visual and hearing status. B, psychological assessment. C, educational assessment, subheadings: norm reference assessment, criterion referenced assessment. D, physical therapy / occupational therapy. E, functional assessment. F, observational assessment. G, behavioral assessment. A, B, C, analysis. Actually, overall, to identify, because the topic is how to assessment only helps us to label the child is multiple disabled child. The primary factor is mental retardation. So it is the assessment overall, not only from the psychologist, because psychology is a must, because the condition is primary factor is mental retardation. Main criteria is the IQ. IQ factor is main for the mental retardation. Apart from it, if the child is showing autism spectrum disorder, again Indian version at present it's in the starting period. We are using PEP and APEP, psychoeducational profile revised, and APEP, adolescent psychoeducational profile, along with the IQ, because adaptive area problem also comes in the sense that doesn't mean multiple disability. We have to do the diagnosis for autism spectrum disorder. Again, we will be doing DSM-4 diagnosis will be there. Actually, assessment and diagnosis the same. When we are diagnosis, the assessment is done from the part, and to label the child as a multiple disability, definitely other hidden talents has to be assessed. Because if it is stereotypic movement disorder, it may resemble like autism spectrum disorder, but it is not autism. But movement will be the same, ringing movement, everything will be. But again, the psychologist during the assessment, one of the factor, if the parents are conveying he is showing routine behavior, jumping, whatever it is, this movement, they have to do diagnosis in both the area. One in DSM-4 for autism spectrum disorder, other in the stereotypical movement disorder. So, during assessment process, to define and label the child, MR is the primary disability and the second associated condition, to label certain thing, it is a overall interdisciplinary team approach.
तो मेंटल रिटार्डेशन इसमें एक डोमिनेंट कंडीशन होगी, उसके साथ जो एसोसिएटेड कंडीशंस हैं उनको हम
overall all assessment has to be gathered together, then only finally we can label the child is MR with whatever we label as associated.
The final diagnosis is always done with that additional team of work. MR is identified, but with associated disorders, that we send it to the specialists or experts of that particular area and get their opinion, their diagnosis about that. Then add it with MR.
मैम, जैसे आपने बताया कि हमारे पास डिफरेंट टाइप्स ऑफ असेसमेंट है, लाइक क्लिनिकल असेसमेंट, साइकोलॉजिकल असेसमेंट, एजुकेशनल असेसमेंट, और उन सब असेसमेंट के साथ ही हम ओवरऑल डायग्नोसिस देते हैं. जैसे कि आज का हमारा टॉपिक ऑफ डिस्कशन है मेंटल रिटार्डेशन एज अ डोमिनेंट कंडीशन विथ एनी काइंड ऑफ एसोसिएटेड कंडीशंस, जिसका हम असेसमेंट करेंगे. ये इस बारे में हमारे एक्सपर्ट हमारे को इन्फॉर्मेशन दे रहे थे. बाकी की इन्फॉर्मेशन हम एक छोटे से ब्रेक के बाद लेंगे. दिस इज टाइम फॉर अ शॉर्ट ब्रेक.
ऑटिज्म एक व्यापक विकासात्मक विकलांगता है जिसके लक्षण जीवन के प्रथम 3 वर्ष में ही दिखाई पड़ते हैं, जैसे असंगत खेल, असमान स्थूल एवं सूक्ष्म गामक क्रियाएं, शाब्दिक संकेतों पर अभिव्यक्ति न देना.
देखो, ओपन योर आईज, ओपन करो, ओपन करके ओपन.
नियमित कार्यक्रम परिवर्तन का विरोध करना एवं अवलोकनीय शारीरिक उच्च स्तरीय या निम्न स्तरीय क्रियाकलाप। UNCRPD 2007 सेक्शन 1 ऑफ आर्टिकल 4 निशक्तता के क्षेत्र में कार्यरत प्रोफेशनल के प्रशिक्षण पर महत्व देता है। ऑटिज्म के क्षेत्र में सरकारी एवं गैर सरकारी संस्थाएं कार्यरत हैं, जो भारतीय पुनर्वास परिषद द्वारा पंजीकृत हैं। सोसाइटी फॉर एडवांस स्टडी इन रिहैबिलिटेशन एक ऐसी ही गैर सरकारी संस्था है। कनिष्क 13 साल का एक ऑटिस्टिक बच्चा है, जो इसी संस्था से प्रशिक्षण प्राप्त कर रहा है। असंगत क्रियाएं, कार्यकलापों में निरस्ता, असमान स्थूल एवं सूक्ष्म गामक क्रियाएं जैसे बॉडी रॉकिंग और फिंगर रिगलिंग उसमें देखी जा सकती है। उसे मैचिंग और पेस्टिंग, पॉइंटिंग जैसी क्रियाएं सिखाई जाती हैं।
वेरी गुड। ग्लास, वेयर इज द ग्लास? ग्लास, वेरी। कप को टच करो जल्दी से, कप को। वेयर इज द कप? वेरी गुड। कप में क्या करता है कनिष्क? टी पीता है। चलो ग्लास, वेयर इज द ग्लास? वेरी गुड। चलो बाउल की तरह, बाउल बाउल जल्दी से टच करो बाउल को। वेरी गुड। बाउल में क्या करता है कनिष्क?
तथा साथ ही साथ रोजमर्रा की आवश्यकताएं जैसे खाना, पीना, कपड़े पहनना, और व्यायाम संबंधी प्रशिक्षण दिया जाता है। ऑटिस्टिक बच्चों को भिन्न भिन्न प्रकार की कार्यविधियां उनके स्तर के अनुसार सिखाई जाती हैं, जैसे कुछ बच्चों के लिए कलरिंग विद इन वन एरिया, मैचिंग एंड आइडेंटिफिकेशन, फाइन मोटर स्किल्स, आई हैंड कोऑर्डिनेशन, कंसेप्ट ऑफ वेजिटेबल्स, फ्रूट्स, बॉडी पार्ट्स, कलर्स पर जोर दिया जाता है तथा कुछ को प्रश्न पढ़ के उत्तर देने में और रोजमर्रा की आवश्यकताओं को पूरा करने में सक्षम बनाया जाता है। इसके अलावा राइम्स, डांसिंग, सिंगिंग द्वारा लेजर एंड रिक्रिएशनल एक्टिविटीज में भाग लेने के लिए प्रोत्साहित किया जाता है। इन सभी कार्यकलापों एवं प्रशिक्षण का एकमात्र उद्देश्य उन्हें स्वनिर्भर बनाना है, ताकि ये डगमगाते पांव सक्षम बन जीवन के एक एक पायदान पर दृढ़ता से आगे बढ़ें और अपनी मंजिल को पा लें। एक तारा टिमटिमाता, उसने आकाश को छू लिया। एक लौ जली कहीं, उसने अंधकार को मिटा दिया।
I don't want.
वेलकम बैक टू आवर डिस्कशन। ब्रेक में जाने से पहले हमने डिस्कस किए थे डिफरेंट असेसमेंट के एस्पेक्ट्स, जिसमें हमने देखा था कि किस तरीके से हम बच्चे के एक प्रेजेंट कंडीशन के साथ हम असेसमेंट कर सकते हैं, जिसमें कि डिफरेंट टेस्ट यूज किए जाते हैं और हर टेस्ट के एक डिफरेंट क्राइटेरियंस होते हैं और उसमें हम देखते हैं कि बच्चा जिस चीज के लिए एलिजिबल होता है हम वो टेस्ट उसके लिए फॉलो करते हैं। नाउ वी विल मूव ऑन टू द डिस्कशन। मैम, जैसे ब्रेक में जाने से पहले हमने असेसमेंट की बात करी है, स्क्रीनिंग की बात करी है अभी तक। अब मैं आपसे पूछना चाहूंगी कि हाउ वी कैन मैनेज द एडेप्टिव बिहेवियर ऑफ द चाइल्ड विद मेंटल रिटार्डेशन एंड मल्टीपल डिसेबिलिटी।
Actually, the adaptive behavior comes overall depending upon, because it is tailored depending upon the child basis. Because when the child, even with a single disability, we can't use only particular way of teaching. Okay, we can't tell to teach a child with a mild mental retardation, use this method or that method. But when the child is having MR with other associated condition, say for example, let us take hyperactive ADHD. Now the child with ADHD, normally even if you won't label as multiple disability, it is the multiple disability condition. Then how to handle the child with ADHD? One thing, medication is enough need. Second, because of the hyperactiveness, we have to structure and how to make the child and how long the child activity we have to schedule. Okay, before entering into the teaching steps, let me just give a overall view of the characteristic features of children with multiple disability. Let us move to the screen. Characteristics of person with multiple disabilities: language delay and or speech problems, limited or no verbal communication skills, lack of basic physical mobility, limited self-care skills and independent community living skills, problems with attention, perception, memory and problem solving, poor retention of skills, slow rate of learning, difficulty transferring or generalizing skills learned in one situation to another situation, self-stimulation, self-injurious behavior, ritualistic behaviors, inability to attend or relate to people, medical problems, example seizures, cerebral palsy, sensory loss, etc. Actually, if you take a child with MR and associated factor, the main thing, already mental retardation gives a meaning the child learning will go in a slow phase. But again, any associated condition adds in the sense, definitely the learning process will be more slower than earlier. Again, being a child with mental retardation, the characteristic features conveys the child attention span is very less. And even memory, again they will forget quickly. Apart from it, from one concept to other concept, moving to transfer the skill transition from one stage to other stage is complicated for a child with mental disability. Again, depending upon the IQ also it changes. Not only depending upon the IQ, maybe say for example it's occurring in our field, the child IQ is mild retardation, but the factor in autism spectrum disorder, it is going to the other moderate and severe level. Even what is the comorbid condition? What is that influence? Because a child with MR and partial sighted training differs, because what is the aspect of the primary factor status and the secondary factor status, both we have to look at, because we have to look from whether the child is, let us don't use the terminology mild, moderate, it is it educable, trainable, what? First we have to focus there. Okay, the child is educable. Then what about the secondary aspect? Secondary aspect does convey the child is having type spasticity. That means then, because our planning is, we to the maximum extent we want to make the child independent in their life, to learn, because lifelong process, even up to their age, they have to spend their time in a useful way, and the cooperation from the parents and the community, we are in need. To prove this, just first we'll go for the tips for the teacher schedule, then I'll explain by step. Let us move to the screen. Tips to strengthen learning. Number 1, structure the environment. A, physical environment. B, time. C, activity. Number 2, provide multisensory information. Number 3, use multisensory approach while preparing materials. Number 4, focus on strengths and special interest. Number 5, plan suitable communicative system. Number 6, plan independent in work habit. Number 7, plan routine in activity progress. Number 8, plan transition and time interval. Number 9, teach change and choice. Number 10, teach finish as a concept. Number 11, provide daily schedules to clarify their activity. Number 12, plan transition and pausing time. Number 13, provide visual presentations. Number 14, Provide hand-to-hand information as a sign language. 15. Implement behavior techniques to strengthen adaptive areas and remedial in problem solving. Actually, if you come for the meaning of multiple disability, main thing, first to focus on the strength of the child, because first thing, because of the multiple severity, the child input in the environment, it won't interact that much. Already the characteristic features of multiple disability, even if the MR is the primary factor, communication problem is there. Now we have to focus how the child expressive language we have to strengthen, or receptive language to strengthen. But when we come for the activity, if we focus on the strength, mean the child first start moving towards learning process, because our main motto, make the child to involve, to understand. When it comes, first thing we have to structure the environment, mean the timing, how long the child has to do the activity, or which area. Because say for example the child is with visual impairment along with mental retardation. Now the input, what we are planning, the activity time, how long, because when the child age is whatever it is, visual impairment in the sense, again the knowledge regarding the environment get delayed, number one. Number two, because of the intellectual problem, the information gathering reduces a lot, and they often forget how to retain it, how to give. That is why you always focus, start and habituation formation, keep the schedule slack in the beginning stage, don't change this, that and all. Let us go in the process in the habit formation, because what we call as a memory trace in our brain, hardly it takes 21 days for memory trace to follow any new learning process to make it a permanent neurological trace. Okay, even that is why to learn driving license training is for 21 days, even for any so-called normal people, because the brain memory trace is the main factor. It becomes enter into long-term memory area. So in the beginning stage, we are teaching a child with visual impairment along with mental retardation. That means we are going to teach a learning concept, labeling the object. So the child may not having hearing problem. Okay, well and good. But only input is what? Tactile. Because glass in an object, we can't make the child to smell. Is the problem. Functional usage we can make the child. But in that stage, the input, better don't change the glass day to day. Use the same. Because the input the child is gathering only in the hand.
It
Second
should be
thing,
same.
secondly, the process intellectual problem is there. We have to understand. If the child is only with a vision problem, I have seen even at the early intervention stage, the child with visual impairment, simply they are touching the object, they are telling this is this person, this is that person. I couldn't understand. Their tactile is very good because their intellectual ability is normal. When the problem comes with the mentally retarded children, in the sense, better don't use the change the object. Then only the child can grasp and the memory trace will follow. Okay, this is the glass. Let me touch, because they are keeping in the order. So it is good for the child. But if the same thing coming along with a child with a hearing impairment, now we have to use the sign language. How? The child can see, but with the hearing impairment, the labeling, the lip sound, we have to focus glass. If one person is telling glass in such a way, means the other person has to focus how to utter the sound and what action again. But again, MR with the vision and hearing also comes. Now again we have to think. That's why always we use hand to hand when the multiple disability increases. Now if it is in the case of autism spectrum disorder, definitely we have to think, because they show normally, even with the multiple disability group, we label, they show 7C. 7C means certain area they will go to the peak, whatever the condition may be. But when mental retardation comes, again with the autism associated condition also, certain area they may show excel. They may. It's not a compulsion, but how to give the information. So definitely then we have to structure the environment, timing, how long, because the child goes under stress factor. To understand the information, it takes time for them due to other associated factors. Say for example, if it is epilepsy, then it's okay. But again, I don't know, certain times parents are having the doubt that when the epilepsy comes, the child may forget the learned things. No, normally there is not such factor. With the epilepsy factor, the child
It is
may
usually
forget.
said that during epileptic attacks, the development is regressed.
people are having, but I have seen certain children, they are getting even very grand mal this thing, they haven't showed any difference at all. It again depends on the child.
It
So
depends
the
upon the
epilepsy-
area which is affected.
Affected.
That is also important.
Important, because if you take the temporal lobe comes for the short-term memory retaining,
Hmm.
near the temporal lobe area, automatically if that area get affected, frontal area comes for long-term memory. Moving from short-term memory to long-term memory, it takes time again. Even that time, in that case, in the severe seizure occurs or grand mal, maybe, but it is not that all children will face that phases.
It again depends upon
Depends
the
on
severity of the
severity of the child.
attacks the child gets,
Severity of the attacks and the
area of
area.
attack.
Area, that's
So
what
both
I am
are
telling you.
essential. Which part is affected? That's the consequence of that. That
Because
kind of an
for a child with multiple disability, main factor if it is MR, we have to think how the retention is maintained by the child. In case if you want structure, and we will make, because why we have to change the finish as a concept, because as the child is doing, the child is not able to understand how long I have to do, because of the other associated factor. If it is even, I can tell hydrocephalus. Hydrocephalus again, water deposition is more and the child always get on drowsy, this factor. Even we can't compel the child to do more time. Then when we are involving the child, even, okay, say for example teaching ADL activity, brushing. Okay, that area we have to focus. The child with the hydrocephalus holding will be okay, better. Let them make him to move. But how to teach the steps? Even we are doing task analysis, backward chaining we are using. But again we have to use shaping method, reinforcement. But there also definitely when the multiple disability comes, first time where we are keeping the brush in the front, then right side, then left side, in the sense we are not supposed to change. That is better for the child, because the routine habituation starts first. Our expectation is, because one day we are starting in the left side, or one day in the right side, one day in the front side, the child may
Confused.
Get
no,
confused.
it's not confusion. Already the retaining is less, already it is forgotten, number one. In case if it is memory is there, again the child get confused where I have to do. Because I can tell a child with dyslexia, even IQ 140, bathing is going problem. They are rubbed right hand, left hand, they have forgotten. Even with such a IQ, because left right understanding itself take problem. But without telling even left or right, this side, this, if it we make as a habituation, routineness,
Consistency should be maintained.
consistency, then only, because as the child learns, we can move to the generalization part. Main the acquisition part is very important when we are dealing a child with MR and associated factor, how the child will acquire it.
And it's very much important while teaching a concept. First we teach it in the isolation, then moving on to the generalization.
Generalization, whether even generalization is normally very problem for a child with multiple, normally. Again in the multiple disability group, in case the disability in MR is at the mild area, IQ is mild, then again the other associated condition is in a milder form, it's agreeable, the child can move to the generalization phase. But again this child is severe on both the side. Let us think how first we'll make the child to learn the concept first. Learn the concept names. Let the child to start an orientation with the environment. Okay, this is the thing. Okay, say for example toilet indication. It's the main problem what we face with the children with multiple handicap is forget about the academic area. Because as the severity increases, it is time pass. We will engage the child. It is not passiveness. But indication of toileting or whatever it is, we have to think what is the suitable thing for the child. We have to think about it. We can't tell for this one means because toilet we are having ones and twos. Both the child has to tell. How come we may understand the child with hearing problem and vision problem along with mental retardation? How the child will communicate now? How the child will indicate now? Because our problem tactile means there we can't keep the object, the child can't search. But in case the child ability is mild MR with a visual auditory problem means we can keep an object. If they don't have any locomotor problem, the child will move nicely and understand, communicate. Because a child, the mental retardation is the major hindrance on the IQ basis. The learning stage and the retention of the learning, it gives a problem. Because when we are structuring the environment in such a way that the child learns mechanically, because honestly if you tell, I can tell boldly, the animals in the circus are able to do the things, how come human beings can't do? They don't have IQ. Even a parrot is learning to ride a bicycle in the circus. How come the child with whatever IQ, they are better, they are having IQs, animals won't have IQ. But the training system, because even in the circus we are using behavior modification techniques only, nothing else. Skinner operant condition is the only thing they are using. It is the behavior. Still now in our educational field we are using Skinner operant conditioning models. All whatever chaining, task analysis, shaping, everything is given by Skinner. Okay, when animals can excel mean then because they are having the habituation, routineness, they won't change and alter the thing, then automatically learning process coming out. So when we are dealing with a child with AMR, we have to think their memory retention, we have to think about it. How long we'll make the memory to retain, in the sense whether the given information is the same or it changes. Already the characteristic features conveys us transition from stage to stage, it is difficult.
for MR.
Then even before starting any functional activity for the child, first we have to focus what is the main thing we will give in the ADL area, even in the academic and leisure and recreation, because we can't think. And luckily in even our India FACP scale helps even for a severe children. Assessment scale we are having. So there is no limitation in our country what input we can give for those children. Only thing, when multiple disability comes, better structure the environment in such a way the child can nicely learn. When I go to this area, I can get this thing, I have to do this, and they already learned change and choice. Change and choice conveys the child is able to understand, if I wish to do, I can, otherwise I can ask absent today. They have the permission, but today I don't want to do, or even in between, because when we are working with a child with MR and other associated condition, we will teach the child, because verbal communication gives a problem, the child can't convey, I am getting bored, or otherwise the child can't communicate to us, ma'am, I am not able to understand what you are teaching. Maybe our way of teaching, because if you take in teaching adaptive area, not only the child's ability, my way of teaching is confusing to the child. Maybe the methodology, what is our presentation as special educators, that time the child can't communicate to us.
It can be any way around.
Anyway.
It may any way around, because we have to agree that from our part also certain times the confusion may exist. Okay, say for example, if I am teaching color concept, I can't cut into the shapes, because shape, circle, square comes in the shape. Then when I am teaching color, do I need to cut in the paper in the shape? No. Then again when I am teaching shape, do I need to use color? Sorry, because normally to teach color concept always it is a line drawing only with a black. Don't use that, comes in the generalization area. That comes in, not comes in the acquisition area.
Aim and objective should be very much clear for teaching the concept.
Because the child can't communicate. That is why we are telling to teach the tips. This one, teach the child change and choice. Change in the sense depending upon the child's verbal or non-verbal. Now choice, he will tell I want to do this, or otherwise I don't want to do this. Only two. Communication board also, because the child, if it's not communicable.
And इससे ये बच्चे को थोड़ा ये भी फील होगा कि yes, he is being involved.
Not only that, the child may feel the control of the environment. I am not a slave, like the environment is controlling me. The child, first time, I am telling honestly, comparing to any other activity, when we focus on the strength of the child. Number two, when we are giving an option for the change and choice and the time limitation, first thing the child feels more independence, that okay, now I have the freedom, I can do this, even any condition severity. I am telling, literally the child is like just nothing he can do, even only head nodding is there. But the child has one freedom, when he nods the head or he refuses, he is getting the freedom to not to do. Because, but again he knows the timing, because we are keeping the timer in the alarm. We are definitely using time. Verbally we are not telling. Whereas the bell rings, your activity stops. Please try it out. Because we are first focusing, first make the child to agree their own limitation also. Because even if they wish, there is a limitation. Number two, when we are giving the input, we have to focus whether we are modifying the environment according to the level of the child's need. Because the child with the multiple disability, if it is one factor, okay, but the multiple factor is more than one, again it is really a big challenge in our hand. It's not that much easier. It's not simple. Even the shaping method, it takes time for the child to understand the meaning of the reinforcement, when they will get and when they won't get. Even it takes time, because as the child is doing, we are giving reinforcement. In shaping means near approximation, we are giving reinforcement. But again, the next step, if the child does any mistake, we are not giving. That time a big tantrum will be there. If it is the child with only MR, definitely the child will wait and think again, the child will look at the eye of the teacher where it goes, and they will start pointing it. They know all the techniques. Instead of looking at the object, really I am wondering about the children's that much this thing. They will look at us where they are looking at, let me point that object. Then they will price, they understood. Even a child with IQ even around 30-35, I have seen it. Okay, but when the multiple disability comes, our main focus is first how we'll make the child, let us have an interaction with the environment. Because MR with more than 2 disability, it takes time. It takes time. Even say for example, if they are coming for the assessment issue in the teenage, certain time it is occurring. Till now they are coming around age 16, and this thing, parents are literally, they are coming, sorry, we have not gone anywhere so far. Now how to start the activity, functional assessment scale, whatever we are using, that is a different aspect. Till age 16, no toilet indication, nothing. He is wetting the pant. Okay, because when we are developing IEPs, it is with the parent concern. We are looking at the priorities based on the child's age also. Because when we are developing IEP to give the adaptive program, parental request also we are taking. Apart from it, the priority goes to the age. Depending upon the age, the activity, definitely ADL activity is the main. Because independency for any child, as the age increases, they forego about the teenage, means parent expectation will be mainly eating, dressing, toileting, grooming, bathing, how to teach, hand washing. That time it starts, because
Prioritization should be there.
there may be certain complexity. Parents may feel, let me start academic first.
Hmm.
Normally they first focus on academics, how much input we can give. This is the early period, he may learn. That tension will be there. Mainly their focus means automatically this everything already getting delayed. As the age increases, one more thing, what we call habit formation, the habit the child so far enjoyed, somebody is doing for them. Automatically, to even I am telling, in the reinforcement technique we call as when we stop the reinforcement to go for the fading stage, it is not easy when we are dealing with a child even with only MR. The fading stage is not an easy stage. It takes time for the child to agree, when I complete overall the activity, then only I will get reward. It takes time. Then even it is a more complicated with a multiple disability group for the child to understand when they will get the reinforcement or when they faded away. Is it agreeable for them or not? If it is non-agreeable, again we have to think whether to implement the use fading system or not. Because ma'am, the child who is learning certain process, even toilet indication or safer, the child is not able to scribble independently, use any adaptive aid, or just somebody is holding. This will in our center, all the severe group of children with MR, just a coffee making machine is there. The children with CP also, everything, vision problem altogether, the caregiver will along the only our expectation, the child's hand will be in the moving this thing, nothing
इट
else.
डिपेंड्स कि जैसे आपने कुछ फैक्टर्स बताए कि एज पे डिपेंड करता है, लेवल ऑफ द चाइल्ड पे डिपेंड करता है, तो इस तरीके से जैसे हमारे एक्सपर्ट ने बताया कि हमारे को एनवायरनमेंट को स्ट्रक्चर करना, उसको
करना
मॉडिफाई
पड़ेगा।
करना बहुत ज्यादा जरूरी है. इट्स वेरी मच इम्पॉर्टेंट और ये हमारा प्राइमरी ऑब्जेक्टिव होता है. फिर हम देखते हैं कि जो हमने एनवायरनमेंट मॉडिफिकेशन किया है उसके लिए हमने फिर कौन सा गोल सेलेक्ट किया अपने बच्चे के लिए, ये सारे टिप्स हमारे एक्सपर्ट ने बताए. बाकी की डिस्कशन हम एक छोटे से ब्रेक के बाद कंटिन्यू करेंगे. दिस इज टाइम फॉर अ शॉर्ट ब्रेक.
The chief handicap of the blindness is not blindness, but the attitude of seeing people towards them. आइए जानने और समझने की कोशिश करते हैं कि बधिरांधता यानी डेफ ब्लाइंडनेस क्या है। बधिरांधता एक स्थिति है जिसमें दृष्टिहीनता एवं सुनने की शक्ति में कमी आती है तथा जिससे विचारों के आदान प्रदान और रोजमर्रा की आवश्यकताओं की पूर्ति में समस्या उत्पन्न होती है। बलराम एक 9 साल का बधिरांत बच्चा है। वो एक प्री मैच्योर बच्चा है जिसका शारीरिक विकास उसकी आयु के अनुरूप नहीं हुआ था। वो एक निम्न वर्गीय श्रेणी से संबंध रखता है तथा 5 साल से लगातार नेशनल एसोसिएशन फॉर ब्लाइंड दिल्ली के प्रशिक्षण कार्यक्रम से संलग्न है। इन 5 सालों के अंतर्गत उसे रोजमर्रा के कामों में, हलन चलन में, उसकी शैक्षणिक जरूरतों के अनुसार संप्रेषण द्वारा प्रशिक्षण दिया गया है जिससे वो इन सब क्रियाओं में स्वावलंबी बन सके। बलराम बिना किसी सहायता के चाकू से फलों को काट सकता है। उनके छिलकों को कूड़ेदान में डाल सकता है। अपने बर्तनों को खुद साफ कर सकता है। उन्हें सही जगह पर रख सकता है। सही बर्तनों का चयन करके खुद खाना खाता है। एवं पानी की बोतल निकालकर पानी भी पीता है। इन सभी क्रियाओं में वो टेक्चुअल साइन लैंग्वेज से निर्देशों को ग्रहण करता है और अपने भावों को व्यक्त करता है। टेलर फ्रेम और ब्रेलर द्वारा गणित, पठन लेखन में भी प्रशिक्षण प्राप्त कर रहा है। सभी बच्चों की तरह उसका भी एक मनपसंद खेल है। उसे सेल फोन को अपने कानों पर लगाकर उसका कंपन महसूस करना अच्छा लगता है। कहा जाता है, वॉकिंग विद अ फ्रेंड इन डार्क इज बेटर देन वॉकिंग अलोन इन लाइट। कहने का तात्पर्य है कि वो लॉन्ग केन ट्रेवल, टैक्टाइल पाथ, ट्रेलिंग और लैंडमार्क्स द्वारा हलन चलन में भी सक्षम है और व्यायाम संबंधी क्रियाएं जैसे ट्रेडमिल, स्टैटिक साइकिल का स्वचालन भी कर सकता है। कहा गया है, द बेस्ट एंड मोस्ट ब्यूटीफुल थिंग्स इन द वर्ल्ड कैन नॉट बी सीन और इवन टच्ड, दे मस्ट बी फेल्ट विद द हार्ट।
Coming back into the discussion that we were doing with our expert, जिसमें हमने अभी तक स्क्रीनिंग, असेसमेंट और मैनेजमेंट पार्ट में देखा था, जिसमें हमारे एक्सपर्ट ने बताया था कि डिफरेंट टिप्स हाउ वी कैन फॉलो फॉर स्ट्रेंथन लर्निंग इन द चाइल्ड विद मेंटल रिटार्डेशन एंड सम कोमॉर्बिड कंडीशंस और एसोसिएटेड कंडीशंस। मैम जैसे ब्रेक में जाने से पहले हमने देखा कि किस तरीके से हमें एनवायरनमेंट को स्ट्रक्चर करना चाहिए, उसको मॉडिफाई करना चाहिए डिपेंडिंग ऑन द रिक्वायरमेंट ऑफ द चाइल्ड, द एम, द गोल्स वी आर टेकिंग फॉर द चाइल्ड। और इसके बाद हम और कौन कौन सी मैनेजमेंट टेक्निक्स यूज कर सकते हैं हम बच्चों के साथ, जैसे हम बात कर रहे हैं मेनली मेंटल रिटार्डेशन विद मल्टीपल डिसेबिलिटी।
There are few steps which have to be followed when you are planning the management of a problem child. As you see in the screen, the steps are first and foremost is the identification of the problem behavior. What is the behavior which is problematic in the child and problematic to others? So that has to be identified by the experts. And then behavioral description of the problem behavior. What kind of behavior and why it is problematic to others. So you have to see the behavior of the child and describe that behavior of the child to know that is the reason why we call it as a problem behavior. Every child has his own behavior and variant behavior. Every child doesn't have the same behavior, but which is affecting others or which is affecting the self, then only it becomes a problematic behavior. So now we'll have to describe the nature of the behavior and why it is problematic. And then the principle of selection of problem behavior. How will you select the behavior for your management purposes? So you have to take one at a time. You cannot attack the child on all areas. So one at a time, so take it with a step by step. How will you manage that behavior? The step by step you will have to take it. And the baseline has to be assessed first before you start any kind of management problem. And you'll have to observe the child for almost a week or so and see whether the same behavior is consistently existing in the child or not. Or it can even change in a day or two. Maybe it is just a situational behavior for the child. So he has overcome it. So, but when you want to correct the child, when you want to introduce the management procedures, you will have to see whether that behavior which we describe as problematic is consistent in the child or not. So for that you will have to watch the child for almost a week or so to say, yeah, it is a problematic behavior in the child. So we'll have to be serious about it and take action on that child. So for the baseline assessment, you need few steps. The first one is event or the frequency recording. Frequency, how many times this kind of, say about nail biting, how many times this nail biting occurs in a child? Consistently he is doing it or interval wise he is doing it. So what is the frequency he has? Again you can measure it for a week or so and see how many times the child has this kind of a behavior. And the duration recording is how long he does it, that kind of a thing. You can note the timings of the child, when does it do. And then interval recording. You have known now the duration. Now he will know the interval. How long does it, is it intervals are there while he is doing it. Sometimes he is not doing it, sometimes he is doing it. So what kind of an interval he has and what circumstances he lives in, that also is very important. So you will note down the recording of the interval occurrence. And then the time sampling is the fourth step. When does it do it? Whether he does it in a particular hour, a particular time, or all the time. So this has to be, time sampling has to be taken to know exactly what some children may be doing the same thing in a particular time only, maybe particular situation only. So you'll have to see when that child behaves in that particular way and how long does it do it. These are the few steps to assess the baseline assessment of the child. Once you know the baseline assessment, when the child is doing, what kind of a behavior he does, what are the intervals, what are the factors. All this thing is in front of you to chalk out a management program for that a child. In the management, you have the functional analysis of the A, B, C. The A is an antecedent, that is, what are the factors contributing to that kind of a behavior in a child. The factors may be many, situational factors. What kind of situation the child behaves like that, or what time does he behave like that, maybe morning and evening, where does he do it, whether he does it in a classroom, he does it in a lunch hour, or does it in a prayer, whatever it is. So where exactly the child does all these things, or is odd behavior, I would say. When you know the antecedents, you can plan out at that particular hour how to prevent the child to do that. And B is its behavior. Behavior is, of course, is very troublesome. That's why you want to manage the child for that. Then what are the factors contributing to that the behavior? So that you'll have to see whether it is one with some situation, or only with some teacher, or only with some particular child in the class. So you'll have to analyze the situation. See when he does it more. With any particular teacher he misbehaves, or with particular child he misbehaves. So when does it go wrong? So that is the behavior analysis, you see. The when exactly, then you can avoid that situation. You may not have the child face him at all. Suppose he is annoyed with a particular child and all the time he slaps him, or being aggressive with the child. You will know exactly that child is not getting along with this child, so remove the child from the situation. Make him sit in another place or not approachable. That kind of a situation you can create. And the consequences of it, why does that child behave like that? When he behaves, there are people around him always. So does he gain by his behavior? Or is there any benefit for the child to behave in such a way? So for one short example I am giving, there is a breath holding symptom in small children, which is not very serious in a way, that the child holds his breath for a few seconds and become a bluish baby, but the parents become panicky. You see, immediately they'll pick up the child and then see what is wrong with this, my child, what do you want, tell me, or insistent crying. So that situation only arises when the people are around him, like his mother, father, or where he can get things done. So the same way temper tantrums is thrown when the child needs something. So he throws a tantrum, and then sees whether my father, mother, everybody is observing me or not, whether I'll get the things I need or not. So the child always sees the situation, whether I can benefit by my behavior or not. If I can benefit, then he will repeat the things again. So we'll have to be very careful there, not to give any attention to that behavior. As far as possible, try to ignore such a behavior, so that the child will understand, nothing can be done, so I should not repeat this kind of a behavior. So the consequences also is very important. When the child is benefited, it always repeats the behavior. If it's not benefited, it doesn't repeat the behavior at all. So the ABC model is very important when you are doing a management with a child. So what are the factors which are contributing to that problem behavior, and what kind of a behavior the child has, when does it have, with whom does it have, where does it have it? And then when you know all these things, the consequences of that, why the child is behaving like that, is he gaining anything, is he benefiting anything out of this behavior, that's why he is doing it repeatedly. So this model has to be analyzed, and then place our management techniques accordingly. What kind of a techniques we should use for the child to come back to a normal behavior. And then development and implementation behavior management programs have to be based on the behavior modification techniques, what you are going to use for the child and things like that. Evaluation of behavioral management program again depends upon what is his baseline behavior, what is his corrected behavior, and how far we have corrected the child's behavior. So that evaluation has to be done by the techniques we are using.
So we have different steps for the management of problem behavior. जैसे कि हमारे एक्सपर्ट ने बताया कि किस तरीके से हम एनालिसिस कर सकते हैं. जैसे एबीसी मॉडल बहुत ज़्यादा इम्पोर्टेंट है, जिसमें हम देखते हैं कि बिहेवियर का क्या कॉन्सिक्वेंस है, क्या बिहेवियर है, क्या क्या एंटीसीडेंट्स है, और उसमें हम देखते हैं कि किस तरीके से हम उस प्रोग्राम को फॉलो करते हुए हम लास्ट में इवैल्यूएशन के स्टेप्स तक पहुंचते हैं. So ma'am, there must be some techniques for the behavior modification.
There are very many behavior modification techniques, and the first itself we'll have to analyze the behavior of the child and pick up the right technique which we can use for the benefit of the child. So that entirely depends upon the problem posed by the child and the technique which you are using. Some techniques are used for encouraging the desirable behaviors, some are undesirable behaviors, so we have to have punishment kind of techniques for the child to undo the undesirable behavior. So that is the kind of techniques we'll have to choose. The first one is for the extinction or ignore kind of a thing. When there is any undesirable, you want to extinct that behavior from the child. So you may use it. I've seen it's a very common use in public also. When the child has a thumb sucking, the child is given some aversion kind of a thing to extinct that behavior. That works out very successfully. I have seen in
certain
many
people
children,
apply certain oil, depending upon the child again.
Child. Some have bandages done on the
क्योंकि mostly all small children has this habit.
That kind of. So that's the extent. Slowly the child is vexed with this kind of a thing and then gives up its behavior. At the same way, ignoring the things. As I said, the tantrums or the breath holding spells, or best is to ignore such, because most of the behaviors of the children are attention seeking. They want always the attention of their parents toward even speech for that matter. So you ignore such things with a child, but at the same keep a watch on the thing which that should not cross the limit of the child. So ignoring will not give satisfaction to the child, because nobody is looking at me, nobody is doing anything for me, so better behave myself. So that kind of a feeling the child gets. So extinction and ignoring for any kind of behavior like that. And then timeout. Timeout is usually used in classroom setups to punish the child, I should say. So when the child is disturbing others or doing some kind of a unwanted thing in the classroom, we use a timeout technique where the child is sent out of the situation for 5 minutes or something like that, so that the child will realize, when I behave like this, I'll be sent out from the class. And it is a kind of a shame also. You see, the other children are there, the child feels, see, मेरे को बाहर भेज दिया, मेरे को खड़ा कर दिया बाहर.
Ma'am, in case if the child does prefer to go out,
Excuse
He
me.
doesn't.
Yes, actually, ma'am, timeout is a procedure we won't give to the child who likes seclusion, who enjoys, because as ma'am conveyed, ABC factor, the consequences, first we focus if we give, ma'am, actually behavior modification technique, as ma'am is telling timeout extension, because we can't use only simple technique. One technique is not suitable. We will be using 2 and 3 together, again modifying and changing it. But timeout, it's maybe we can make the child, in case if the child's activity is coloring, is preferable. He is disturbing the class, but it is preferable activity. If we won't make the child not not to do, he will get tense. That time he won't do the prayer. That time timeout is simple. We will make the child to sit in the class but far away from
Far
the
away.
table. Okay, that time the child learns. The child will learn, okay, let me don't do this thing, because it is his preferable activity. Number one. Number two, if you make the child not to do, he can't tolerate it. It's a disturbance for him. Then only he will change his maladaptive behavior he is doing in the class. But some children, they enjoy time out in the sense, definitely they will repeat, because consequences conveys us whether
It's
time out,
benefiting the
whether
child
to
or
select
not.
or not. Time out we can't select all of a sudden. We will first overlook whether time out is needed or not needed, whether the child engage from the place. If you take the behavior management technique, time, even ignoring as ma'am said, breath holding. See, we can ignore for a certain time. Again, if face a certain medical problem to the child, we have to
Then we
That's
can't
what I-
ignore.
because
that's what
it
you can't
is
ignore. You have to keep a watch on the
because
child
it
at the same
occurred,
time.
yes ma'am, it occurred in the classroom
Correct.
situation. It is attention seeking only.
Yeah.
But the child has understood earlier he get attention. Now he is going not getting attention, in the sense he is going to the extreme. He is increasing it a lot. That time we are getting tense. What will happen next? So all the techniques, certain time why we are changing, because again depending upon the child's
So it's entirely
responses.
depends on the conditions and the problem behavior the child is having.
Because it's a multiple disability group. It is not only child with MR or any particular disability, multiple in the sense other channels. Already ma'am, behavior modification, we are telling it's a problem behavior. But if it comes even for autism spectrum disorder, we'll label it as a communication. Because already the child is not getting environmental input. Second, the child can't play because they can't learn rules and regulation in doing any activity. To understanding, even if you give any play item, they don't know the rules and regulation. Then how come the child engage himself? Definitely they will try to involve in the environmental people to get attention over them. So problem behavior we may simply label. But if it is self-hitting, yeah, hitting others, spitting on others,
Spitting.
or like this, then we have to think why the child is doing what. Because there are what we call as a differential reinforcement technique. Alternate behavior, it is a medical problem. The child is always spitting me. We'll make the child where to spit, give a ball, do the spitting over here. Even throwing object, honestly, we are giving throwing if the child enjoys it. First, what we call the overcorrection, in the sense, make the child to sit in a place.
Put it in a
Continuously, we
particular
won't make the
place.
child to stop. Because it's exhaustion, let him commit out, but we will make the child where to do, when to do, where not to do. Because multiple disability means in the characteristic features itself we have conveyed they will have self-stimulation. Then just to think about it, is it possible for us to take self-stimulation, rocking as a problem behavior? We have to think. Before taking a problem behavior,
But if it becomes problem when the
in his
rocking-
learning,
yeah.
in his learning, or
Learning,
whether he
and if
interferes
it
in
affects
others'
other
learning,
child,
then
is it-
take it as a behavior modification technique. Otherwise, think it is the characteristic feature. Self-stimulation will be there.
Yeah.
Is it interference in his learning? That time, think about the problem behavior modification. Otherwise, we have to leave it.
Leave it. Let
Because
child
the
enjoy it.
behavior which is problematic itself says it interferes the learning of
Learning
the
of-
individual or in the others learning.
We are that is what I am telling you. Differential reinforcement technique, in the sense, during the session time, the child has to sit quietly. We are giving break time. That is what I conveyed in the tips. Give the time transition, pass along time break. That time we will allow the child do the rocking. We won't make the child to stop it. It is the neurological imbalance. It's a starving. It's the starving of the child. Then only they are getting satisfaction. How come we'll black it?
Stop it.
Restrictions cannot be made.
But that is what change and choice, in the sense, yeah, definitely the child will get an option for self-stimulation. But finish this activity, then go and do
Then
in
go.
your break area. Because with any multiple disability, it's not, even especially we are doing with autism spectrum disorder, but not only with autism spectrum, visual impairment along with hearing and mental retardation comes, definitely the self-stimulation will be there. Certain time there may confusion, is it a autistic child? There is question rising like that. But when we diagnose autism spectrum disorder is absent, that means self-stimulation is a characteristic feature. That means no, it can't be taken as a problem behavior modification to stop it. He need other therapeutics, other medicine. Apart from it, our focus modification technique will come under particular timing. He has to control. Afterwards, he will get an outcome. What we call it as a differential reinforcement techniques. Okay, let us view it on the screen. Techniques for increasing desirable behavior: differential reinforcement of opposite behavior, differential reinforcement of other behavior, differential reinforcement of low rates of behavior, differential reinforcement of higher rate of behavior, differential reinforcement of alternate behavior. Apart from, as ma'am conveyed, the techniques timeout, extension, physical restraint, all are coming. Apart from it, definitely we have to give alternative suggestion what to do. Because when the child, okay, say for example thumb sucking, it's good. If you are making the child to stop it, the child has to engage in what? That means
we have to
alternate.
give some alternative
activity.
activities.
Otherwise, our behavior modification technique doesn't
Fails.
work.
will not work.
Even if you apply oil, okay, the child is not sucking, but the
But
child
what
will
to do
identify new
other?
problem behavior because it's a boredom. Then what is the alternative behavior? Then think about the child's, what is the preference? Because always when multiple disability comes, we always focus on what are the strength of the child. Tackle it.
We always focus to the positive part.
Positive.
Positive part. Then because nowadays behavior modification techniques are comes in the secret other companies, we call as a positive modification techniques. First to focus what could be the alternative suggestion, so that because behavior problem behavior we simply label because we are not able to manage, cope up with it. But from the point of the child get boredom. He is not getting environmental resources to engage himself. All the communication blockage will be there. Other sensory modality is there. Again, because of mental retardation means IQ problem, understanding the activity and playing even without rules also. If you give carom board, simply they may do or twice or thrice.
If it's not the interest of the child.
Interest of the child.
How to engage? What are the fine motor object? What? Nothing. There is no partner with them during playtime. That first we have to understand any problem behavior comes. This is the thing the child want to engage himself busily in the environment. Whether it interferes or hurts himself, then the techniques okay. But again we have to think when the multiple disability comes, already they are facing a problem not to get required inputs for their understanding about the environment and people around them. So any behavior modification technique when we are using, whatever it is, first we have to think how we will make the child to get the input that the environment is soothing him. He can request the environment also to satisfy his need.
We will focus on to the preferences of the
Preferences.
child. तो मैम जैसे आपने बताया कि जो हमने मैनेजमेंट टेक्निक्स की बात करी, अगर हम कहें टेक होम पॉइंट्स फॉर द व्यूअर्स, तो ये हम कह सकते हैं कि हमें ये देखना है कि चाइल्ड की प्रेफरेंसेस क्या हैं. वी विल फोकस ऑन टू द पॉजिटिव पार्ट ऑफ द चाइल्ड.
Ma'am, preference इसलिए ले रहे हैं. First we want to make the child to understand his request. The environment is ready to agree. If he pass along it as a request. If he command and throws means the environment is not agreeing it. First we have to make him to understand the environment where all the people or whatever it is, they are ready to help them, to help him. First thing, how he has to convey to the environment his need. He's boring because it's simple for us to tell the child is temper tantrum. But the child is having multiple disability along with him or two more disabilities there. Full time, how we will engage his time, we have to think about it.
So we have to think in terms of the
Alternative.
perspective of the child. जैसे कि हमारे एक्सपर्ट ने बताया, आज का जो टॉपिक ऑफ डिस्कशन इट वाज रिगार्डिंग द स्क्रीनिंग, असेसमेंट एंड मैनेजमेंट ऑफ children with mental retardation with some associated conditions or comorbid conditions. इसके बारे में informations दी हमारे expert ने. Thank you so much ma'am for giving these informations to our viewers. That was all about the today's session. This is time for the closing of our session. Thank you so much.
Thank you.
எப்படி இல்ல இல்ல